Hi, thanks for joining us. I'm Mohammed Bashir, and today I'm with a true renowned international aortic surgeon and a true pioneering and aortic giant who is also the founding and the director of the Aortic Institute at Yale and Yale New Haven Hospital. It's Dr. John Elefteriades, and I'm truly honored to spend time with you today and to ask you a few questions about the thoracic aortic aneurysm, reading the enemy's playbook. Thanks for joining us, Dr. Elefteriades. My first question is, it's a broad question. What's aortic aneurysm to you?
Aortic aneurysm is any significant enlargement of the aorta, the main blood vessel of the body. And the definition has been problematic over the years. But what I would use is a diameter of 4 centimeters. There's probably no human being who should have an aorta more than 4 centimeters at any level, from the aortic valve to the iliac bifurcation. Others have used a diameter 1.5 times the adjoining normal segment, but it's often difficult to identify an adjoining normal segment. I think a definition of 4 is a valuable one. A basketball player who is 7'2", he might be entitled to a little bit bigger aorta, but 4 is not a bad number to use.
Okay, you've been the dynamic heart on a multiple facet for the natural history of this disease. What do we know now of the natural history of this silent, in your words, silent killer or stalker?
We took this challenge on like a sports competition.
Yeah.
And when we were all playing sports in school, we had a playbook. And that playbook would work for American football, it would work for European football, baseball, basketball, wrestling, any sport you can imagine. And each team's secrets were very closely guarded in that playbook. So starting about 18 years ago, we took this as a competition that this silent killer of thoracic aortic aneurysm had a playbook. And we recognized that we did not know what was contained in that playbook. And we knew that from sports, if you could get the opposing team's playbook, you'd be in a good position for the competition. So for the last 18 years or so, we've been trying to read that book. And we have learned a lot. We have learned that aneurysm is a silent disease in the vast majority of patients, which makes it very dangerous. I wish it were not a silent disease. And we have learned that it tends to rupture or dissect above a certain size criterion, somewhere around 5 to 5.5 centimeters. We have also learned that that criterion varies based on the individual's body size. So we've been able to specify a nomogram that incorporates body size. And as we put in one section of our journal, of our article in the JACC journal, JACC, in 2010, a paradigm of triage to medical management or surgical management using size as the main criterion keeps patients safe. Basically, out of hundreds of patients that came to our office, when they were triaged to surgery or medical management, nobody died. Now, the one point that I always emphasize is that size applies only for the asymptomatic patient. The patient with pain of origin in the aneurysm has to be operated regardless of size. And a misunderstanding on that point has hurt many patients. A symptomatic aorta has to be removed regardless of size. We do know that the aorta is innervated, especially the ascending aorta. It's innervated by fine neural fibers.
Yeah.
And so when it is under great stress, we feel it can, in some individuals, transmit that to the brain and cause pain. So pain has to be very, very highly attended to.
Great, Dr. Elefteriades. You mentioned the predictions and the predictors of yearly rupture. Do we need to do anything more? Do we need to know more?
That's a very perceptive question, Mohammed. And although I've been a proponent of using size, and size has served our surgical community quite well, I feel very strongly, as your question implies, that we have to move far beyond size. And we are working hard on engineering parameters. We've measured them very accurately in the operating room. We'd like to be able to transition to measuring by conventional imaging techniques. I think engineering is critically important to be able to measure the stress in the aorta at different levels. And then I think that the genetics is critically important. And we're on the threshold of a completely new era. If you think about it, about 12 years ago, maybe 15 years ago, no human genome had ever been mapped. And there was a race between Celera Genomics, headed by Craig Ventnor, and a consortium of universities from around the world to map the first human genome. And it's contested who won. It was pretty much a draw. But the first human genome ever deciphered was that of Craig Ventnor, the president of Celera. And that cost hundreds of millions of dollars. Now we can map the whole genome, we can sequence the whole genome easily for $5,000. The true cost is probably closer to $1,000. And the $500 genome is right around the corner. So we are at an unparalleled opportunity to know the genome of our patients with aneurysms. And then through the work of Diana Milowitz and others, we have categories now of variants or mutations that behave differently. So we will very shortly, and we can already to a certain extent, triage patients based on the particular mutation that they manifest. And we know that mutation A and mutation B and C don't behave exactly the same. So there will be a different criterion for every different mutation. And you and I were both surgeons. We love to cut out the aorta. We love to put a new aorta in. It's challenging, it's demanding, it takes a lot of skill, and we love doing it. But I think we're on the threshold of a new era where genetics will play a very important role.
Good point. You mentioned bioengineering, and there is a question which I'd like to ask you. What are the mechanical properties of the aorta, and how this affects our understanding of natural history?
In simple terms, when the aorta grows, when it gets beyond 5 centimeters, it loses its normal elasticity. In you and me, the aorta stretches with every heartbeat. But as it grows above 5 centimeters, it loses its elasticity and it becomes a rigid tube. So every heartbeat is translated to a tremendous tensile force in the aortic wall. And if it exceeds the ultimate tensile strength of the aorta will tear. And that's what we believe happens with aortic dissection. Right. If we take pieces of human aortic tissue and we stretch them in 2 directions, which we do with our distinguished engineering colleague, Dr. Wei Sun, the aorta fails first, just like a dissection, through the intimal and medial layers, and the adventitia remains intact. So the bottom line is that as it enlarges, the aorta loses its normal elasticity. Because it's inelastic, it suffers a very high wall tension, which we believe makes it vulnerable to aortic dissection.
That's a beautiful point. What can you tell us of the family patterns that you tend to see, especially that you're working on the genetic side of aortic aneurysm?
Mohammed, we stumbled upon the recognition that thoracic aortic aneurysm is a familial disease. Of course, everyone has known about Marfan's disease for over 100 years. But we were making rounds one day, Marianne and my team and I, on a middle-aged woman on whom we had repaired a type A aortic dissection 3 days previously. And we asked her, she was well enough to have a conversation, and we asked her, has anybody in your family had anything like this? And she smiled and said, Doctor, don't you remember you operated on my mother? Of course, I had no recollection. That was several years earlier. And then we asked her if anyone else in the family had been affected. And she became tearful, unconsolable. And come to find out, her daughter, her 12-year-old daughter, was the youngest human being ever to die at our hospital of a type A dissection. So there we had 3 generations in one family. And that's when our residents and our students went to work constructing family trees. And the long and short of it is that we found in 21% of our patients with aneurysm, there was a family member with a known aneurysm somewhere in the body. And imagine, if you will, how high the true incidence must be if 21% already have had an image that has disclosed an aneurysm. So we feel, especially for the ascending aorta, that it is a highly genetically mediated disease. That's how we stumbled on it. Dr. Diana Milowitz in Texas had a year or two before found the exact same number that we found. And if you take her data and our data, you can superimpose them perfectly one on the other.
Yeah, it's great. I want to stay with the gene therapy. And you said that there is a promise for gene therapy in the future. What do you anticipate would that be, and what would happen to surgery?
Yeah, well, I'm a heart surgeon like you. I'm not a geneticist by any means, but I do recognize how important genetics is in thoracic aortic aneurysm, probably in every single human disease. So I've tried to learn a little bit, and I've tried to push genetic investigation as much as I can. Now, when I am very encouraged about the enhancements of our care that will come about through genetics, I'm not talking about going in and modifying the genome. That may be possible in the not too distant future. But I'm thinking that knowing the mutation can help us predict for a particular patient how that aorta will behave. Furthermore, if we know the mutation, then that should take us through basic science to the protein that's affected. If we know the protein that's affected, then I am hopeful that conventional drugs can be designed that can prevent the aneurysm from progressing and causing complications later. Do I think that this will eliminate aortic surgery? I don't think so, not by any means. Maybe after my generation and your generation, maybe something will happen. And if you'd like, we can speak a little bit about drug therapy for aneurysms. But I think that perhaps in the long term, maybe for children being born today, if they have the gene to cause an aneurysm, maybe by the time they're young adults, we'll have drugs that are targeted to the particular mutations.
Excellent. Staying with the point of drugs, Dr. Elefteriades, what's happening to losartan and the beta blocker? There is a big controversy going on. Could you just put our minds to rest with your own views and comments?
Well, mankind has always wanted a magic pill for everything.
The elixir.
Yes, always. Everybody wants a vitamin that they can take to prevent heart disease. And every candidate molecule or drug has failed to be confirmed for heart disease in general. Now, Dr. Hal Dietz and his colleagues have done the most tremendous scientific work implicating the TGF-beta regulation in the causation of Marfan's disease and other aneurysms. Just the most superb, high-quality research. And it all suggested in the animal model and in very young infants and young children with Marfan's disease that losartan was having a beneficial effect. And I had the privilege of sitting with Dr. Dietz in his office and seeing the graphs and seeing the aortic size just stop growing. So there was tremendous hope for losartan trials, and they started all over the world. And the biggest one was recently reported, and I had the opportunity to review that study. And the bottom line is that losartan did not meet its expectations in this large clinical trial. The hypothesis was that it would cause better results than beta blockers. There was no placebo arm. The comparator was a beta blocker. And it just didn't meet its goal. Now, maybe the dose was too low. Who knows what else may have gone wrong. But the other important point that I think we have to stress for our colleagues in medicine and surgery who deal with the aorta is that even the comparator of beta blocker is very poorly substantiated. And we put a review as a letter to the editor in NEJM that has a table that Dr. Bulat Zaganshin from my team, our research director, put together of every study of beta blocker treatment for Marfan's disease. And it's a very mixed bag. There's never been a demonstration of a positive clinical effect. And to use a beta blocker as a comparator, I just want people to know that it's not an established, proven treatment. I wish it were. Now, we always want to do something, and beta blockers, they make sense in a way because they diminish the cardiac impulse. Yeah. They make it softer. Yeah. And I personally think that their most important effect may be at blocking epinephrine storms, yeah, which can come from physical exertion or from an emotional event. We know now that 2/3 of dissections are triggered by an extreme emotional event or an extreme physical exertion in a patient with an enlarged vulnerable aorta. I think the biggest benefit of a beta blocker may come from putting a cap on the severity of the epinephrine response to those stressful events. I think it'll cap the heart rate and the blood pressure, and that may be the biggest benefit of a beta blocker. I don't start patients on a beta blocker myself. They usually come to us on a beta blocker.
Excellent. I know that you're doing a different type of research on different levels, different grounds. One of which is amazing, is the genetic sequencing that you're doing, and I'm hoping to join you as a postdoc at some stage. Would you like to share with CTSNet viewers and subscribers a breakthrough and something that you have achieved on that line?
Well, there are two answers I can give to that, Mohammed. One is that we have been fortunate to sequence a lot of human beings with aneurysm disease. Yeah. Dr. Alan Bale runs our sequencing laboratory, and we have already complete results on 105 human beings with aneurysm. Nice. There are another 75 cooking. It takes a long time to read 2.2 billion letters of a genetic code. So we have looked for all the variants that Dr. Milowitz and others have identified for Marfan's, Loeys-Dietz, Ehlers-Danlos, and all the familial entities. And we found already, among those 105 humans, 21 new variants that are very promising as disease-causing mutations. Yeah. They're all different letter changes, but they reside on genes known to be involved in the development of aneurysms. So that we feel is very exciting. And we feel that very quickly, through work at multiple centers, we'll have a dictionary where you can look up the letter change, know if it's causative for aneurysm, and then know the behavior of patients with that particular mutation. That's all based on the work of Diana Milowitz and others. That's one point. A second point has to do with the silent killer nature of aneurysm disease that you pointed out. Because it's a silent disease, the biggest problem is to identify in the general population individuals who have an aneurysm. That's not easy to do. Once we identify the individual, you and I, our teams, we're not going to let them die from the aneurysm. We'll triage them based on size, symptoms, whatever. And we won't let them die. We'll intervene in the vast majority of cases before an aortic event occurs. But the problem is to identify them. So we, together with scientists from Celera and Applied Biosystems, we looked at 33,000 different RNAs in the peripheral blood of aneurysm patients and compared them to normals. And we found the RNAs that were most up or down regulated. In other words, the most dysregulated from you and me and other people without aneurysm disease. And we put 41 of them on a chip. And it turns out that that chip can distinguish with an 80% accuracy whether you have an aneurysm or not in the thoracic aorta. So we're very excited by that. We have replicated that already in a different population. We're doing a third replication, but we're excited. We feel it does have the potential perhaps to identify patients in the general population. I'm hoping it could be like a PSA for prostate cancer, but we're not at the stage of clinical application yet. It's a research tool at the present time.
Sure. Great. Dr. Elefteriades, I know that you've got a long day ahead of you. I'd like to thank you for the time today. It's been an honor talking to you and taking your interview for CTSNet. Thank you very much.
Thank you, Mohammed.
Thanks a lot.
Thank you.